Good morning all. I would like to say thanks to JB sir and the scientific committee of AIOS. The topic of my presentation is update on ocular toxoplasmosis. I don't have any financial disclosure. Toxoplasma gondii is regarded as world's most successful known parasite. This obligate intracellular protozoan parasite is highly transmissible and can even alter the host behavior to facilitate its own transmission. It's believed to affect 1/3 of the global human population. It is the second leading cause of death from the foodborne illness in USA, and every year WHO estimates that 1 million cases of toxoplasmosis in Europe are caused by contaminated food. It is also considered as one of the 5 neglected parasitic infection by the CDC, which was taken for public health action. Coming to ocular toxoplasmosis represents the most common cause of posterior uveitis. In few case series, it was one of the most frequent form of infectious posterior scleritis, representing up to 85% of the all cases. If we see the global scenario, it's highly endemic in Latin American countries, especially the Brazil. It's also very common in European countries and some sub-Saharan countries. However, it's very low. The low prevalence is observed in countries like China and Japan. Now coming to the India, we can see there's a high prevalence rate from the northeastern state, where the Das et al. Has published a study in where the 40% cases of the posterior uveitis cases were ocular toxoplasmosis. Similarly, from southern India also we can see this 25% of the cases of posterior uveitis was due to toxoplasmosis. So coming to the life cycle of the toxoplasmosis, we can see this definitive host is the cat or the feline family, which where the sexual reproduction occurs, and the oocyst, which is the most infectious or which is then excreted into the environment, and the mammals like human beings and the other mammals are the end stage intermediate host. Now keeping this life cycle in background, we can easily formulate the various routes of contamination. It can contaminate the milk and water. It can be contracted through the ingestion of unwashed fresh vegetables or fruits, or ingestion of raw or undercooked meat. Now, hematogenous spread is one of tachyzoid is one of the important cause for Toxoplasma chorioretinitis. They spread through the bloodstream and involve the retina. The most important or most common cause is the release of Toxoplasma gondii from the intraretinal cyst, where the cyst lies dormant in retina, containing lots of bradyzoid, and in under favorable circumstances they convert into tachyzoids and causes inflammation of the retina. So many researchers call this as a Trojan horse mechanism, and they believe that this is the most common method of infection of ocular toxoplasmosis. Autoimmune responses are believed to cause a lot of inflammatory changes in the vitreous and the retina and optic nerve head. So these are also important mechanism. Now coming to the lesion, initially it starts as a superficial retina. It involves the superficial retina only. Now at this stage, if you examine a case, sometimes you may misdiagnose it as a case of retinitis. You can see here the early involvement in the ocular toxoplasmosis. So gradually the retinitis progresses and the full thickness retinal involvement occurs. Gradually involves the adjacent choroid also. That's why the name retinochoroiditis is used. First retina is involved, then the choroid is involved. Then gradually the products of the inflammation or debris accumulates in the vitreous, giving rise to the classical headlight fog in appearance, where a unilateral solitary active lesions is seen in the midst of significant vitreitis. Now, it can also present with sometimes localized vitreous haze. Various researchers has described it as a keratic precipitates of the posterior vitreous face. So, examination with 78D or 98D lens helps. Sometimes, if the patient is already on corticosteroid, you can see the ocular toxoplasmosis with absence of any vitreous haze. And its toxoplasmosis tends to be a disease where it's a very recurrent, up to in 1/3 of the patients presenting with relapses. You can see the healed, and you can see the active retinochoroiditis near this healed lesion, which is known as the satellite lesion. A 30 years old male presented to our OPD with a diminution of vision in left eye. The vision was counting fingers. Anterior chamber examination shows cells of 0.5 plus, and there was plenty of cells in the anterior vitreous. He denied any history of contact with major illness or any history of contact with pets. On examination, you can see there is a peripapillary hemorrhage, optic nerve head swelling. There was a retinochoroiditis patch here, and you can see the subretinal this exudative detachment. So serum AC, serum lysozyme, all investigation was non-contributory. So we took the aqueous aspirate for mycobacteria and Toxoplasma genome, and the aqueous aspirate was positive for the Toxoplasma genome. So we started on anti-Toxoplasma treatment, and after 1 month you can see the visual improvement. He responds to anti-Toxoplasma therapy dramatically, and this was the picture after 6 weeks. So now optic nerve head involvement has been described in literature by Cart and all, where the swollen optic disc with presence of distance lesion was very common. It can also presence with neuroretinitis like this. Here is the retinochoroiditis patch. You can see the macular star appearance. Here is another picture. You can see the retinoitis patch with lot of exudates. Now coming to the important topic, ocular toxoplasmosis in immunocompromised. It remains one of the most common cause of non-viral opportunistic infection of the CNS. The risk of AIDS patient with positive Toxoplasma serological test, the risk is approximately 6 to 12%. Fortunately, only 1 to 3% of ocular infection in patients can develop Toxoplasma infection. Now, when to suspect this ocular toxoplasmosis in an immunocompromised patient? If the patient presents with bilateral involvement, if there is a single discrete lesion with out of proportion vitreous inflammation. Now, these lesions, it need to be differentiated from the CMV retinitis. So, the only differentiating features are the severe vitreous inflammation in case of Toxoplasma retinochoroiditis and lack of granularity at the lesion border in Toxoplasma. Now, another important point is the multifocal discrete lesion. If you see the multifocal discrete lesion, then you should suspect Toxoplasmosis, and if you see the retinal necrosis. This is very commonly seen in immunocompromised patient, and sometimes if the retinochoroiditis is located peripherally, then it can mimic acute retinal necrosis. So how to differentiate this? The lack of circumferential spread in such lesions and not responding to antiviral therapy can differentiate these lesions from the toxoplasmosis in HIV patient. Now, whenever we see such patient, neuroimaging is must, and if one should prepare for the frequent recurrence after the discontinuation of the anti-toxoplasma drug. Now, coming to the retinal vessels involvement in ocular toxoplasmosis, you can see here this often can present with vascular occlusion. It can present with periarterial arteritis. You can see here it's also known as Carylis plaque. Historically, it was first described in a patient of tuberculosis, so it's not pathognomic of Toxoplasma gondii, can be seen in various other infectious uveitis, but it's most commonly seen in the Toxoplasma chorioretinitis. So if you see with this retinochoroiditis lesion with this kind of plaque, then one should suspect Toxoplasmosis. You can see here. The one characteristic feature of this Carylis plaques are they remain confined to vessel wall. Unlike the sarcoid uveitis or the frosted branch and angiitis, they remain confined to the vessel wall, and when we do FFA, they don't leak the fluorescent dye. So this is the characteristic feature of the Carylis plaque. Now coming to the laboratory diagnosis of ocular toxoplasmosis, there are several methods, but one should remember that the diagnosis of the ocular toxoplasmosis is almost always clinical. Now, don't treat based on the serological test. Don't treat a patient based on the serological test alone, because the serological tests are often positive in general population and don't necessitate any treatment. Now, ELISA for the anti-Toxoplasma gondii is most commonly used and most commonly available test here. Now, if you see the antibodies to Toxoplasma gondii, you can see the IgA occurs early after the acquired Toxoplasma gondii infection and disappears earlier than the IgM antibodies. Now, this IgM antibody occurs after 1 week of infection, picks up at 1 month, and disappears after 9 months. And the IgG, the problem with the IgG, it takes 3 months time to appear, but it persists for years. So you can't rely upon the IgG for the diagnosis. But however, if it is negative, then it can exclude the diagnosis of Toxoplasma. And 3 to 4-fold rise in the anti-Toxoplasma IgG antibodies should be considered as a significant, and one should investigate such case. Now, the IgA, recent reports are there that the IgA has been used extensively for the diagnosis of ocular toxoplasmosis. The problem with IgA antibodies is that the commercial kit is not available, and it's very costly, and it's mainly used for the research purpose. Now, coming to the PCR for aqueous aspirate and the vitreous specimen, you can see it helps in the diagnosis of atypical presentation of ocular toxoplasmosis, but it should be judiciously used because it's less sensitive for the diagnosis of Toxoplasma gondii in ocular fluids than the viral diseases. I'll give just one example. The Harper et al., they done a large series of 133 patients in suspected infectious posterior uveitis. The PCR of ocular fluid to have overall sensitivity and specificity was 80.9% and 97.4% in case of herpes viruses. Whereas in case of Toxoplasma gondii, the sensitivity was only 67%. That's why the PCR should be used judiciously in Toxoplasma gondii. Now, the measurement of specific local antibody production in ocular toxoplasmosis is more sensitive. So, one should use this Goldman-Whitmer coefficient when it is available, to that proportion of which measures the proportion of specific immunoglobulin in ocular fluid versus the serum sample. It was Goldman-Whitmer coefficient was positive in 90% cases, where the PCR testing was positive only in 36% of the ocular toxoplasmosis. Now, coming to the treatment, I don't want to go into the details because my next speaker will discuss this topic. Only problem with the treatment with toxoplasmosis is the ability of the toxoplasmosis to transform into the tissue cyst. This is the most successful strategy of this parasite, and these cysts are permeable to the host enzyme and can avoid immunosurveillance by the host easily. So that's why we don't have any drug that can eliminate the latent cyst from the retina. So the only option is the prevention of toxoplasmosis. Now, how to prevent this deadly disease? Just to follow the 5 keys of safer food proposed by the WHO. Now, what is this? Keep clean, keep the environment clean, separate raw and cooked material, cook thoroughly, keep food at safer temperature, and use safe water and raw materials. Thank you.